Okay, so I think at this point of time, Ravi, we will have a coffee break. What's the time now? Pune is live. Pune is live, but we have to have coffee also. Can we request the coffee can be served here? Okay, we'll serve the coffee here. Dr. Hiremath is online. So if we can do this live transmission, because they are more expert, they do regularly.
Not to keep trying to pull back. Tell them it's fine.
Okay, I think we request them to get the coffee here while we are doing this live transmission. But can we hear this, Dr. Hiremath? Dr. Hiremath, can you hear us, Dr. Hiremath?
Yes, we've been hearing you for a little while already.
Okay,
can you hear?
You see, we had some technical
And
problem
it's recording, you
from
can't
Dr.
disconnect it.
Rajiv Bhagwat. Unfortunately, they were not listening to our voice. And when I saw your picture, beautiful picture, I thought, let me say goodbye to you and take you to sleep.
All right, so are you with us?
Yeah, we are with you, and what we'll do, we'll not have a coffee break, we'll serve the coffee inside. We have about 100 people inside the room. I don't know whether you're seeing us also. Dr. Samba from South Africa will be one of the main discussants. And may I request a few people from the audience also to join us in the panel. Let me see the scientific program. Professor Alec Premier had a fantastic lecture just now. He showed his live in box, but there as well. And he's just gone out and he is joining us in a while. So Dr. Zambakite will take over and he will just tell the case to him. So let me introduce Shri Hiremath is one of the important person and highly skilled in doing their cases in Pune. I think he's the largest volume in Maharashtra. I don't know whether you must know better. But he's a very kind soul and he agreed to do this live transmission only on 5 days notice. I'm so thankful to him. Shirish, are you hearing me?
Yes, as usual, Dr. Makhay is with me. All of you can see him. Can we go to this case presentation, the first slide?
Zambakite will take over.
Clip cancel करेगा.
Dr. Zambakite.
Hi, how are you?
Oh, pretty good. How are you doing? I hope you remember your visit to Pune.
Yes, it is. How can I forget? It was excellent.
Okay, thanks for coming. So we are live now with this 69-year-old diabetic individual. As you can read, he had surgery in 2002 following an anterior wall infarction, and he has 5 grafts. The RIMA was used. We'll show you how the grafts were placed. He was asymptomatic for the last 10 years and presently is with us for exertional dyspnea. LV on echo is 40% with basal septum and anterior wall hypokinetic. So this is the old damaged. Can you show us the sketch? Yes. So this is how it is. Can you move it a bit? Take out the picture in picture. Okay, you can see the Lima graft is joined to diagonal and LAD. And the RIMA is joined to ramus, OM, and PD of RCA. On the angiogram, the Lima portion between diagonal and LAD, as shown in the diagram, is completely occluded. So Lima at the moment is supplying only to diagonal and not LAD. The RIMA graft joined in a Y fashion to Lima is occluded between Lima and ramus. So that portion is occluded. The graft between ramus and OM is actually functioning very well. So this is a functioning graft, and the graft between OM2 and the RCA PD is again occluded. So we have only a little bit of surgical procedure functioning today. The diagonal is protected, and the graft between ramus and OM2 is functioning. So we now come to today's imaging. The target today is the RCA, the LAD, and the ramus. So this is the first picture. You can see a very tight lesion in the proximal LAD. It's a long segment stenosis. Next. Hello. You can see a tight lesion in the ramus, in the proximal portion. And you have a circumflex which is running close. Circumflex looks pretty good. Next. Next run. So you can now see the surgical graft which is functioning between ramus and the distal RCA. The circumflex is a dominant vessel, RCA also is a codominant kind of circulation. Next. And this is the RCA, which is not really a big circulation. So this is the amplas. Okay.
That was a JR.
This was a JR. So we have finished the right stenting. It was a pretty straightforward. Just go through it.
Also the Lima also. The Lima is going only up to the
Okay. This is Lima for you. It is going only up to diagonal, as I mentioned. Dr. Zambagrai, you are able to hear us and see us?
Yes, we can hear you. We're just listening and looking at the case, and then we'll discuss afterwards.
So this is the RCA angioplasty, balloon dilatation. We had to use a multi-hole catheter because there was wedging of the pressure. And then this is the Zion stent.
No, this was Genexing.
This is Genexing?
Yeah.
Okay.
So the Genexing box 323. 2.75.
What size stage was that?
This is a Genexing 323.
So we have covered the ostium in this particular case. And you can see the ostium is very well seen in this particular view. Run it again. So Genexing has been one of our favorite stents here. Can I have the slides on Genexing?
Yeah, we are seeing that Shirish Dr. Kliber has just joined. Then you can say hello to him.
Hi Alan, how are you?
Hello, good to see you. Good to see you.
Long time.
Good luck. It's an
Yeah, we haven't seen you in Pune for a long time.
You can speak from there. You can speak from there.
I'll come again
So
for
this-
hunting grounds in your center.
So this is a Genexing stent that we are talking about. It's a sirolimus eluting stent. These are very... Have we lost you?
Now we can still hear you.
Yes. So this is a very thin struts, 0.63 compared to conventional ones which are above 0.65 and 0.68. Next slide. The surface is very smooth. Next slide. And drug release kinetics is fairly similar to most of the drugs that we come across. We did a gel registry in Ruby Hall, and here we studied long and very long lesions. Next. And by that we mean we took lengths which were 40 and above. The longest length that we get with Genexing is 40. And sometimes we use two stents to overlap. So these are some of the follow-up results. Our success rate was 95%. And you can see 6 months follow-up on LAD first, then the RCA, and another case showing RCA. And they were all very nice results. We had diabetics which were about 40% odd. And we have total of 54 cases. Can you go back to the previous slide?
Next.
Next. No, go back. Next. Okay, stop here. So 54 cases, there were 6 months follow-up on 40 cases we have completed clinically. 25 cases have been re-angioed, and we have 13 IVs done. Next. And as you can see, in hospital we had one death. This was mostly complicated with renal failure and acidosis. Next. And you can see the 6 months follow-up has shown excellent TLR, TBR in this subset. Next. So overall, we feel this has been one of our very favorite stains. Even in such long lengths, we had event rates which were very, very small. Having done the RCA, we have now moved to the left side.
What is the plan there? What is the plan there?
And let's discuss what can be the possible plan. Vivek, how much time do you have on two cases we have? We have about 50 minutes.
I'm not sure what time is allocated, but I'm sure we should be able to have 40, 50 minutes.
Oh.
Hopefully.
Okay, don't zoom, just show us the, okay, freeze this. So Alan or Dr. Zamraght, the issue is how would you approach the LAD and Ramus intervention? We can see, show some other view too. That's the
Go back.
radial graft.
Next. Next. Oh, stop it.
Don't zoom, just show it. So are you able to see this clearly? There is a tight lesion in the Ramus location.
Yeah, we can see it quite clearly. I mean, it's a very proximal
Next.
lesion, and it's definitely a bifurcation lesion, so you're going to need to have a look and see, but it appears to be a 0-1-1 lesion. And I'm sure from the onset you're going to try most probably for a two-stem technique.
I think on most of these cases, we like to use rotablator because the disease advances pretty rapidly in the native vessels once they are grafted for a long length of time. So many times we also see calcium in these, and our choice today is rota to LAT, rota to Ramus, and then consider stenting. You all agree, or somebody would probably skip rota and just go with a non-compliant balloon for pre-dilatation?
It seems quite calcified. I mean, if you don't have IVUS, I would normally go for IVUS. If it's got concentric calcification, definitely go for rota. If there isn't concentric calcification, either non-compliant balloon or either your angiosculpt or cutting balloon just to prepare the lesion. But definitely you need to prepare the lesion before you proceed.
So the other point, go to aleocaudal, any aleocaudal view of left side. See, the issue is which one you would address first, whether it should be LAD or whether it should be Ramus. The reason why I'm asking is the LAD ostium looks a little bit free of disease, while Ramus is truly ostial location. Show some other view in aleocaudal. Okay, show that previous view again. Yeah, freeze that, just zoom that. So here you can see very clearly after the origin of circumflex, there is a clear zone at the ostial LAD location. So LAD is not truly an ostial lesion, while circumflex looks a truly ostial lesion. So why I'm saying is, so many times when we place a stent right at the ostium, the passage of the next stents sometimes becomes an issue. So here our plan is to stent the LAD first and then go to Ramus because Ramus is an ostial lesion. So let's see the way we have approached. We have the microcatheter exchange for the rotawire. This is the conventional rotawire. We have used 1.5 burr for the entire length of LAD. There wasn't too much resistance. You want to comment?
Yeah, but there was a fall of RPM from 180,000 to almost 140. It required a multiple pegging, and after that it was just smooth. As you can see at the polishing runs, really it looks good. Next. And this was the rota result.
So at this stage, we had a little discussion as to how do we do rota leaving the wire in LAD. because if we leave a wire in LED, put another wire in Ramus and spin the rotaper, there were concerns whether it could hurt the side branch wire which is in the LED. So we took a calculated risk and actually we pulled out the wire in LED. And then we have the wire, rota wire in the Ramus. Next. So at this stage we have bought the LED, but there is no wire in LED, which is a little bit of risk, but I thought it's fairly acceptable.
Well, it's a very small risk because in rotablator you very rarely, if ever, going to lose a side branch because you're drilling, you're breaking little pieces off which go distally. So it's not really that you're doing a balloon where you're going to get Clark shift.
Sorry, I don't think we picked up what you said. Did you get it?
No, I couldn't make out. Can you please repeat it, what you said?
I was saying it's not really a huge risk because with rotablator you're actually debulking, you're breaking pieces off very small which then go through the microcirculation. So it's very unlikely, it's almost unheard of that you're going to lose any side branch. Whereas if you were going to do a pre-dilatation with a balloon, yes, then you would get Clark shift.
Okay, we actually removed the wire at that stage and we did a rotablator for the Ramus and it was a really hard lesion. Go back to the rota. Yeah, so it required a little longer time here and after that we could do the polishing runs and it was fairly good. Next. So the rota result was fairly good. Next. And now we are here at this particular stage. Next. Where both LED as well as the Ramus have been rotablated and we have got a de novo wires in both these vessels.
So we are with a non-compliant balloon NC in LED. Can you show us the balloon? And we did a pre-dilatation to the LED. Let's take opinion from you all on the length of the stent that we should be using. So this is a 15 length non-compliant balloon. So you all agree we could use a 38 stent?
It's going to be a long length stent. You've got to cover the whole diseased area, especially since you've rotablated all the way down. So yes, 38 millimeters.
So for this, we have chosen Science 3538. We take one more picture since we had almost 15 minutes discussing the case. So we are with 7th French EBU. Open the stent.
Open.
Let's do it quickly.
Yeah. That's fine.
Get an NC balloon 35. Go to RAO corner. So we are getting the stent in. How is the weather in Zurich, Vivek?
Can you hear me? Shirish, can you
Yes,
hear me?
yes.
The weather is quite cloudy, but of course Switzerland is Switzerland. The temperature is about